So hi everyone, welcome to teaching again. So this is today we've got one of our surgical colleagues. This is Chris Mann. He's one of the colorectal surgeons, and yeah, he's going to talk to us about nutrition on ITU and I think a little bit about stomas potentially as well. And following on from that, I believe we've got one of the registrars from the Royal. I think it's Dan Walker, going to talk to us about the INPRESS trial. So yeah, over to you, Chris.
Hi guys. Hopefully, I suspect most of you probably know me. So I was given the topic of the surgical abdomen and surgical nutrition, which was a bit too much for 40 minutes. So I thought we'd just have a little discussion on surgical nutrition. Also, and then if we get time, a bit on stomas, particularly high output stomas, which I think are quite badly done. And then if we get time at the end, a bit on fistulas, which we do see quite frequently, particularly at the Royal. So there you go. So why is it important to talk about nutrition? Well, at least 50% of the hospital population are at least moderately malnourished. We know that poor nutrition increases morbidity and mortality, slow wound healing, impaired muscle strength, particularly respiratory muscle, which clearly has implications for when they're ventilated, impaired cardiac function, and also immune dysfunction. And this translates into longer hospital stays, longer cost, and also kind of long-term poorer quality of life. There's been quite a few studies linking malnourishment to development of severe serious complications after surgery. The first part of this really is trying to work out which patients we need to focus on and make an assessment of them. Obviously, a vast proportion of our patients, particularly the emergencies, will come in with pre-existing malnourishment. Those at risk of, particularly those who've had an insufficient intake for 5 to 7 days beforehand. In the emergencies, obviously, we're talking about potentially the obstructive patients, but also in an elective situation, the upper GI patients, the IBD patients in particular. And then we have to think about the operation that they're going to have, either again elective or emergency. Are they going to be able to resume their dietary intake within the 5 to 7 days afterwards? And if not, we need to think about them. For the most part, elective surgery, particularly colorectal, but others as well, oral nutrition continues really without interruption. There are obviously exceptions to these. Patients who are having high anastomoses, particularly upper GI surgery, although by and large they have feeding jedges put in. I think the other group are those that have prolonged adhesiolitis and they end up having high risk of ILIS post-operatively, and therefore they may well not be able to continue oral intake immediately post-operatively. And the ESPEN guidelines, the critical care ESPEN guidelines for nutrition in critical care patients, basically their statement is that every patient staying for 48 hours or more should be considered at risk on ITU, should be considered at risk of malnutrition. We start talking about assessment. Again, like everything, we start in the history. Those who tend to be older, more risk of malnourishment, high frailty scores. Those with quite extensive comorbidities, cardiorespiratory. And then really the main things in the history we're looking for are the weight loss. Clearly we have to be careful in those with fluid shifts, edema, ascites, but by and large significant weight loss, particularly in a short period, is a red flag warning sign. Other things that may give us a clue: patients with poor appetite, nausea, vomiting, difficulty swallowing. And then obviously the disease process, patients with particularly inflammatory conditions, chronic sepsis or advanced cancers, they're going to score quite highly. And then in the emergency patients, patients with peritonitis, ischemic bowel, they're again also going to score highly. When we look at examination of the patient, we commonly look at BMI, which does come into this, but we must remember that obviously obese patients have high BMI and they can still be malnourished. Muscle mass is probably the best indicator that we have, so-called sarcopenia, but again, there's no standardized way of assessing this. Quite for all the anthropometric tests of muscle strength really are not really necessarily appropriate in an intensive care environment. Blood tests, we tend to look at albumin. Now, albumin as you all know, is a negative acute phase protein. It will go down in sepsis as it's diverted, but it is an independent marker of poor outcome. So whilst it's not a marker of nutrition per se, it is a useful tool. And then clinical judgment, which I think is probably the most important factor. If you look at somebody and go, they look malnourished, that probably counts for more than all of these markers put together. Certainly within UHL, we use the MUST tool, which I'm sure you've all seen, which really comes down to weight loss, BMI, and comorbidities to assess their risk of malnutrition. I've nicked this slide from the Chris course manual. I don't apologise for that, because it's quite a nice slide, really. If we look at the metabolic demands, the nutritional demands of patients relative to baseline, if a normal ward patient with an infection is between a quarter and a half more, septic patient on intensive care 60% more, and then complicated surgery. And if we think about the patients we have on ITU, quite frequently they've had complicated surgery, they're septic and they're ventilated. So you can easily see how quickly their nutritional requirements shoot up. These are the SBEN guidance. I'm not expecting you to read them, but these are the SBEN intensive care, nutrition and critical care guidance for assessing patients at risk of malnutrition. Again, the main factors here are weight loss greater than 10% within 6 months, BMI of less than 18 if they're under 70, or less than 20 if they're over 70, assessment of muscle mass, which is difficult, and then the etiology and the disease burden. Okay, and they classify severe nutritional risk into weight loss, again within 6 months of 10%, a BMI less than 18, and again an albumin of over 30. Occasionally, particularly with elective or semi-emergency patients, we need to think about, is there any role for preoperative nutrition? The studies in patients with severe, clearly in an elective patient, we largely try and start them on oral nutritional supplementation. If that is not possible, other routes of enteral nutrition are ING feeding, which is quite frequently as an inpatient. And if that's not possible, then PN or a combination thereof. We know that in patients with severe nutritional risk, that preoperative feeding for 10 days beforehand leads to a 30% reduction in morbidity and an associated reduction in mortality. I think the important thing to mention with this, it's got to be a disease process that the nutrition is going to be of benefit. Quite frequently, patients with advanced cancers, the cancers basically just eat up the calories rather than the patient actually getting them. And similarly, in the patients with chronic inflammatory processes, IBD, nasty fistulae and Crohn's disease, nasty colitis, there really is a very limited role with preoperative nutrition in these patients prior to resecting the pathology. And this is a discussion we quite frequently have with the nutrition team at the Royal for the IBD patients in particular, that actually getting on and operating them and removing their inflammatory focus is of more benefit than trying to nourish them preoperatively, because quite frequently it really has very little in the way of impact. We'll go on to talk about the routes of feeding. If someone's gut works, it's always the best. So enteral route is always preferential. We'll come on to the reasons for that in a bit. Oral nutrition, particularly oral nutritional supplements, if they can eat and drink, we use these in pretty much most of our kind of elective patients, and post-operatively the ward patients if they can tolerate them. The enteral nutrient, we know from several studies that if oral nutrition supplements are not possible, the early enteral nutrition versus parenteral nutrition is of benefit. I think there's several ITU studies that starting early enteral nutrition, IENG or JEG feeding within 48 hours improves outcome. we'll come on to the reasons for why we start low and progressively increasing them in a bit. The enteral nutrition versus PN really has been shown to have lower infective complications, lower anastomotic leaks after GI surgery, improved length of stays. And again, early enteral nutrition, there's a lot of evidence for improved outcomes in other critical conditions, trauma, general critically ill patients, major GI surgery, and acute pancreatitis. I think the days of fasting patients with acute pancreatitis really are over. And I think that's a message that's been kind of slow to come across. I think the exception to the enteral route, there are some absolute kind of contraindications where we would go straight for TPN, and there are some relative contraindications. Clearly, if someone's got an obstructed GI tract, that's potentially an absolute contraindication. In a patient who's got ileus, I think that's a relative contraindication. Post-operative ileus, we quite often trickle in a bit of nasogastric feed as a kind of a gut protective mechanism to maintain the blood-gut barrier, and if they tolerate that, build up from there. But quite often they need a combination of enteral and PN nutrition. High output fistulas is commonly a contraindication to enteral nutrition, unless you can establish feeding into the distal limb of that. We'll talk a bit more about that later on, but if you can feed distally or into the distal limb, if it's like a loop fistula, or establish a distal feeding with, for example, a radiological jedge, then enteral nutrition is of benefit. And I think the other contraindications are abdominal compartment syndrome, bowel ischemia, and things like acute GI bleed. When we're considering how we're going to feed the patient, we need to think about the advantages and the disadvantages. Hopefully, this should be just a bit of revision for you all. When we look at enteral, by which we in the majority we mean NG feed. The advantage is physiological. There's less kind of sugar and electrolyte and triglyceride disturbance. It's cheap, it's easy to do, and it's effective. The main disadvantages really relate to the tubes. Difficulty in getting one in, difficulty in getting a pH, and getting an X-ray to confirm the position, it being pulled out after they've had the X-ray. We've all heard the horror stories of patients being fed into the wrong place, and the never events that arise from it. Clearly gastroparesis and aspiration is also a risk, and that's why starting slow and building up is one reason to do that. First line prokinetics for gastroparesis, and again the ESPEN guidance is it's IV erythromycin followed by metoclopramide if that doesn't work. And again, they're two drugs that we quite frequently do use. And then long-term risk of having the tube in someone's nose of pressure necrosis. The guidance, if the feeding's for more than 4 weeks, then potentially surgical routes, PEG, or feeding should be considered. And I guess lastly is the osmotic diarrhea. When we look at kind of parenteral nutrition, we're looking at the risk related to the line and the line insertion, and then the metabolic complications. Putting the line in, you're all anaesthetists, so clearly these are familiar to you, of causing pneumothorax, the hemothorax, lines going in the wrong place, falling out, and then the longer term risks of sepsis, line thrombosis, blocking, breaking, falling out, and leaking. The metabolic complications really are pretty much every metabolic complication you can think of. We'll talk a bit about refeeding syndrome in a minute. See sugar disturbances, electrolyte disturbances, and elevated triglyceride levels with the impact on liver function and cholestasis, and then in the long term liver disease, progressively eventually cirrhosis due to fatty liver and fibrosis, and also stone disease. Refeeding syndrome, I have to say, is something that as a registrar I never really understood. It's something that we're not very good at thinking about, certainly as surgeons, but it's something that the nutrition team are quite frequently all over. When someone is a patient's in a catabolic state, everything's been broken down. When we switch them to refeeding into an anabolic state, we get insulin relief and release and potentially fatal shifts of the fluids and electrolytes, particularly phosphate, magnesium, and potassium. During refeeding, the increase in serum glucose leads to the release of insulin, which leads to glycogen, fat, and protein synthesis, which uses up the phosphate and the magnesium, and uses up the thiamine, which is a coenzyme in carbohydrate metabolism. The insulin also stimulates the cellular uptake of potassium, phosphate, and magnesium, which leads to hypokalemia, hypomagnesemia, hypophosphatemia, and their associated clinical syndromes, as well as thiamine deficiency and vernix encephalopathy and Korsakoff's. There's fairly clear, nice guidance and BAPLAN guidance for identifying patients at high risk. I'm not going to read them out. They're in the bottom part of the slide there. Basically, it's similar to assessing patients at severe nutritional risk, really. And in terms of managing the patients, again, there's nice guidance on this. Really, it relates to correcting thiamine prior to refeeding, with usually intravenous thiamine, multivitamins if practical, monitoring the electrolytes and starting the feed low and slowly building up from it. Okay, so that's all I've got to say, kind of quick thing on nutrition. Or I can take any questions at the end. So the other thing I thought we'd kind of talk about, which kind of ties in, is stomas and management of high output stomas. Now, again, this is something that's not done particularly well. It's fairly clear. There's a nice protocol on the intranet and UHL, which, to be honest, if you're stuck, is a pretty good fallback. There's really no standard definition of a high output stoma. Lots of numbers in the literature are bandied about of over 2 litres or over 1 litre. But really it comes down to, are there any electrolyte or fluid issues or nutritional issues associated with that stoma output? So it's all relative. Causes really, causes really are fairly extensive. Clearly, if we've done extensive bowel resections, that will be a long-term cause of a high output stoma. Crohn's, bowel ischemia. Some people's bowel doesn't work, particularly if it doesn't pump or if it's being irradiated. In a patient with a kind of a known stoma after, I don't know, an anterior resection and defunctioning loopy ileostomy that suddenly develops a high stoma, there are a high stoma output. There are other things you ought to think about. Intra-abdominal sepsis is probably the most common one. Subacute obstruction. So if there's a partial adhesional obstruction, that will frequently present with a high output watery stoma, and particularly in the IBD patients, someone with an ileostomy after a subtotal colectomy, steroid withdrawal, and I think that is one that we're pretty poor at picking up. And then lastly, C. diff, and pretty much any other GI infection, but particularly C. diff in someone with colostomy needs to be thought about. It is quite frequent after a new stoma is made for it to not work for a few days with an eyelid and then go bananas. I think when we're talking about high output stomas, we traditionally use that definition for after 48 hours of it being formed, and although we can probably say after 48 hours of it starting working. So the treatment principles of high output stomas are to really, is there anything reversible we can treat? Give them steroids if they're Addisonian. Is there any sepsis that we can drain or treat? Any pelvic collections being the common one. Are they on any prokinetics? Is this a stoma, someone who's had an eyelid for a while? We've given them loads of erythromycin and metoclopramide, and then suddenly the stoma's got working and gone bananas. And again, quite frequently we forget to stop the prokinetics. Replace their fluid and electrolyte losses, if they're losing 2, 3, 4, 5 litres a day and associated sodium and potassium with it. Skin protection is a big thing. As I'm sure you all know, small bowel content is very alkaline, and if it's very watery, the bags will burst, it will get onto the skin, and you'll get peristomal dermatitis, ulceration, and skin breakdown. So really, stoma nurses, if the nurses in HDU are struggling, are very good at helping with that. And then we do have some methods for reducing stoma output, which we'll talk about. Does the patient need nutritional support, which quite often, particularly if they're post-operatively, that they will do. Psychological support, again, this is more of a long-term management that with these patients. If this is a long-term high output stoma, it's pretty miserable. Spending ages in the hospital trying to sort it out. And then again, in the long term, is it possible to recruit more bowel into circuit? So the expected volumes are, if someone has got, now this is dependent on if this is just small bowel or have they got an ileocecal valve and this small bowel pumped onto an intact colon. But generally speaking, if they've got less than a metre, we'll expect them over time to adapt to 2 to 4 litres stoma output. Again, and that progressively gets less. Really, the cutoff we're looking for is 2 metres of small bowel, and then if we know they have that, we're usually fairly optimistic that we can get them to kind of independent living. That being said, even our elective ileostomies after an anterior resection, we know that 20% of them, so up to nearly a quarter of them, are readmitted with high output stomas, and the majority of which have a degree of AKI associated. So they're not benign. They're not benign things. So again, the management, really don't rush in too quickly, other than supporting their fluids and electrolytes, particularly in the first 48 hours after it starts working. We tend to use loperamide as a first port of call. It's important to open the capsules, because otherwise the capsule doesn't get absorbed and it just comes out in the stoma bag as an intact capsule. Tend to ask patients to kind of sprinkle it onto a bit of yogurt or a bit of jam or something just to make it a bit more palatable. I'm sure you know loperamide is an opiate, and it binds to opioid receptors in the gut wall and reduces peristalsis. Initially, we ask them if they're tolerating oral intake to go on a high salt diet, and we start them on a PPI, usually a omeprazole 40 once or twice a day to reduce kind of GI secretions. The next step after that is we fluid restrict their hypotonic fluids. So hypotonic and hyponatremic fluid intake causes a net shift of sodium followed by fluid into the gut and drives increasing stoma output. So we tend to restrict them to 500 mils of hypotonic fluid and make them drink a litre of St. Mark's / WHO solution, which is a hypertonic electrolyte solution. It's not very well tolerated. It tastes pretty gross, and even if you mix it with orange or Vimto or something, it's still pretty bad. Patients are not great at complying with that, so I think that does need to come into consideration when we start talking about it. But that couples the coupled reabsorption of the sodium and the glucose in the jejunum, and with some shift of fluid back from the gut lumen back into circulation, improves sodium balance. It doesn't necessarily improve stoma output per se, but it does tend to improve electrolyte balance. You can use double strength diurolite. Instead, single strength diurolite isn't hyperosmolar enough, so you use double strength, but it has got quite a lot of potassium, so you need to kind of closely monitor the potassium if we go down that route and they don't tolerate WHO solution. If that doesn't work, I think in ITU, hopefully you've sent them to the ward by this stage, but we put them nil by mouth for 24-48 hours, really just to work out quite what their baseline GI secretions after that. Strict fluid balance, monitoring all their electrolytes, particularly potassium and magnesium, and replacing them along with their fluids. We increase the loperamide on a stepwise basis, usually initially to 8 milligrams QDS, but you can go up to 24 milligrams QDS And again, starting on codeine, that tends to be the next step. If that doesn't work for a couple of weeks, then we give them a trial of octreotide to see if that does anything. Okay, so that's a little quick run through high output stomas. And I thought we'd lastly just have a little, which it's quite related, is a talk about fistulas, and mainly intracutaneous and intraatmospheric fistulas, mainly because you can show some nice pictures. We've all, I'm sure anyone who's worked on intensive care at the Royal has seen these, hopefully not as a result of my operating, but more as a result of emergencies. So we quite often see people with open abdomens with VACs on and then developing a fistula as a complication of a VAC. Now the management of these is tricky, it's long term. It wouldn't be the first time, we've had anaesthetists go, or someone go, why aren't you just taking this person back to theatre because they're pouring small bowel content anywhere? So I thought it'd be useful to have a little chat about that. Usually this isn't an immediate surgical complication. This tends to happen a few days down the line, and once you are a few days down the line, the bowel is stuck together. It's become all inflamed, all friable. It tends to kind of have the consistency of kind of slightly solid cottage cheese. It's a very bad time after about 7 to 10 days to go back inside someone's abdomen, particularly if particularly when it's like this. The bowel's all fused together. You'll try and go back in to reset this bit. You'll make far more holes because the adhesions at this time are far stronger than the bowel are. And even if you manage to get in and reset this bit, you're stitching together something with no strength, and anything you do will just fall apart. So really, it's a case of supporting the patient until they are fit enough, things have matured enough for them to undergo further surgery. There's a nice mnemonic called SNAP, which I think probably every surgical registrar knows. But essentially, this is all supportive care, and this is a long-term supportive care. Particularly an intraatmospheric fistula, by which I mean as someone with an open abdomen with a hole in the small bowel, pouring small bowel content out. That really is a devastating complication of a damage control laparotomy. The patients are in hospital for months. We're talking months, if not years, of sorting them out, with very high morbidity, high mortality, and obviously costs and hospital stays. We tend to classify fistulas based on their output, which I'll go back to the pictures. Really, the cutoff we tend to look at once things have kind of settled down is 500 mils in 24 hours. If it's over 500 mils, that's what we classify as a high output stoma. They tend to need nutritional support, and it's unlikely to close in the long term. Whereas a low output, which is less than 100 mils, does tend to kind of close spontaneously in the long term. The causes are often iatrogenic, and we've talked about VACs already, like prolonged adhesiolisis and missed enterotomies or serosal tears that then blow in the resulting ileus, and anastomotic leaks, obviously, trauma, spontaneous malignancy, and obviously Crohn's in particular as well, quite often gives rise to intracutaneous fistulas. And then TB is something we do obviously see from time to time in Leicester. About a quarter will close spontaneously, and you tend to give it up to about 3 months to see if that's going to happen. Things that are against it closing, we mentioned high output fistulas. If you've got the other things are if you have diseased bowel. So if you've got a section of active Crohn's disease, that's never, or radiation, that's never going to heal. Distal obstruction, again, that it's going to preferentially exit, bowel content's going to preferentially come out the fistula. If you've got a short and particularly short wide fistula, so that falls into the bracket of all these intraatmospheric fistulas, they're never going to settle on their own. Whereas something, a long thin fistula from a small anastomotic leak down someone's right paracolic gutter may well settle. And then the site of where it fistulates from, clearly a proximal fistula, it's going to be more likely to be high output. So duodenal, jejunal and even ileal, they are unlikely to settle spontaneously, whereas a colonic fistula, or a fistula from an appendix, or a colonic fistula from a perforated diverticular disease may well settle. The initial management, particularly of a high output fistula, is sorting out their fluid state, resuscitating them, sorting out their electrolytes, which may well be grossly abnormal, and then sorting out sepsis. That really, sepsis is associated with the majority, kind of 80% of the morbidity and mortality associated with fistulas. Clearly, that may well involve antibiotic therapy, but it also involves draining any sepsis. We're largely reliant on imaging for this, and preferentially imaging-guided sepsis, imaging-guided drainage of intra-abdominal collections. Going back to what we said before, these sorts of patients, we're not going to be able to get back into their abdomen without wreaking havoc to drain a paracollic collection. So really, this is something we need our radiologists to do. Occasionally, we do get our hand forced and do have to re-operate on these patients to drain sepsis, but this, we quite often results in more fistulas. And again, going back to what we said before, the priorities are, exteriorise. There is no point trying to anastomose anything in this situation. Other than draining sepsis, the next thing we have to think about is the nutrition of the patient. Patients with low output fistulas are quite often managed very adequately on oral nutrition, with oral nutrition supplementation. Clearly, those patients with high output fistulas, we end up relying on TPN. We quite often do end up managing the high output fistulas on a combination of enteral and parenteral nutrition. And on top of that, we employ similar strategies to how we manage the high output stomas in terms of slowing them down, loperamide, codeine, PPIs, etc. Really, resolution of the fistula is a fistula is never going to close if the patient does not have their fluid and electrolytes sorted out, does not have their sepsis corrected, and does not have the nutrition sorted out. Along with that, again, from a surgical point of view, we then, after 3 months, start thinking about long-term. Going back to nutrition, I mentioned earlier, the other thing that we can try in terms of enteral nutrition is if we can establish distal limb feeding. So for in particular, somebody who's got a bit of small bowel on the surface, if we can thread a catheter, collect the effluent from the afferent limb of the fistula, we can do fistulolysis and feed down the distal limb. It's not something we do an awful lot in UHLs. It's something we have done from time to time, and to basically feed what they're pouring out into the distal limb of the fistula, usually with a Foley catheter. Anatomy is something we ask our radiologists for help for. That has really where the fistula is, how much bowel we have between the DJ flexure and the fistula helps us in terms of planning nutrition. If it's near the DJ flexure, we're going to have to start thinking about long-term TPN. Counselling the patient, how long is this going to settle? Again, we need to be realistic with managing them, and obviously planning surgically for the long term. Like high output stomas, wound care and skin care protection is important. We've tried varying methods of protecting the skin. Using a fistula back is a relatively new thing, and actually this is, if we can establish one, really is our best option of isolating the fistula in the middle of the vac with a stoma bag on it and then vacuuming the rest of the wound. Quite frequently that's not possible. I'm sure we've all seen patients with big wound bags on, which really are not very satisfactory. We've tried things like putting catheters down fistulas, which do work from time to time, but quite frequently they just fall out. So if we can, this is our preferential treatment to establish a fistula vac. And what we're after is really, over time, getting the wound to heal around the fistula, like it is here, and essentially leave us with what looks very much like an ileostomy. The aim of kind of long-term aim of a definitive operation is to get in there, not make any more holes, and put them back together and it work. This all comes down to planning and timing. The patient needs to be the best possible place for this to happen nutritionally. Quite frequently, you can go in after 6 to 8 weeks, but it's difficult, and we have to factor the disease process into this. Someone with an open abdomen after peritonitis, we are not going to be able to operate after 6 to 8 weeks, as opposed to someone who's had a localized perforation brought out as a kind of a double-barrel jejunostomy. We may well be able to go back in early. This sort of patient, realistically, we're looking at 6 months, if not a year, of nutritional therapy, which may well be home TPN, to leave them in this state before we can reoperate on them. This isn't someone I operated on, but we did, a couple of years ago, we did put back together a young lad who had 14 ends of small bowel coming out of his midline, and actually did very well, put back together, GI continuity restored on independent nutrition at home. So it really is possible, but it is a long journey. We tend to start thinking about this after about 3 months, if it's still not closed by that time. There we go. So that's SNAP. So that's fluid and electrolytes. Sort out the sepsis, sort out the nutrition, define the anatomy, protect the skin. And again, like high output stomas, psychological support. These patients are in hospital for months, they're miserable. And, you know, we need them participating with nursing care, wound care, participating with physiotherapy to enable us to plan definitive treatment down the line. Any questions? Hopefully that was about right for time.
That was perfect, Chris. Any questions from any of the guys, the Royal or Glenfield, anyone else who's listening?
Deathly silence. Deathly silence. Anyone asleep?
Sorry, are you able to hear us okay?
Yeah.
Yeah.
Thanks for the really nice talks. It's Justin here, I'm just off screen. So is there going to be any kind of advance on vac dressings in the future, or are they just kind of a necessary evil? Because it seems as though they kind of cause almost as many problems as they solve.
I'm not sure vac dressings do cause. I think putting vac dressings on incorrectly causes problems. To be honest, if you ask my, you know, the people I've seen fistulate, I'm not saying this is 100%. I mean, you got to remember we do use a lot of vac dressings, and we don't get that many intraatmospheric fistulas. Whether the ones we do get are due to the vac dressings, are they due to a pathology that was missed at the time of surgery, or are they due to the vac dressings being put on incorrectly? The ones I've seen, my gut feeling has been it's been because the vac dressing's been put on incorrectly. I'm going to be honest, this is one of my personal bugbears, that vac dressing changes get left maybe to someone who hasn't done that many of them, and this is something that we've raised a lot of times at surgical M&Ms. I had a young woman who fistulated, who later died, and who you know, when there was a piece of foam that hadn't been covered, you know, it hadn't been protected for the bowel and was welded onto a bit of bowel, and then she later fistulated from that site. So I think it's an educational point of view. It's you know, so I can't. We have there are other things we do try for the open abdomens. Quite often they do involve vacs. We've tried putting absorbable meshes in, and if you can, shutting the skin over the top, which to be honest is nice because that avoids a vac dressing and, you know, recurrent trips to theatre and prolonged hospital stays. That's not often possible. quite a new thing is using mesh assisted closure. So what we do is we put the inner liner, the aphthera, in. We then put a piece of mesh on top, stitched it to the anterior abdominal wall, and then the rest of the vac on top. And then we bring them back over a few days, cut a piece of the mesh out, and basically try and ratchet their abdominal wall back together with a view to, eventually closing. You get some idea after a few vac changes if that's actually going to work, but that does avoid needing a vac dressing for months, then skin grafts, and then ultimately a massive incisional hernia with loss of domain that is quite frequently nigh on impossible to fix. So there are things we have tried. I think vac dressing versus the alternative of an open abdomen with a wound bag that leaks and is a nightmare to manage is preferable. I think lots of the problems come down to it being left to a very junior person to put them on. If you want my opinion, I don't know. There's a few noddings there, so I've obviously not. Yeah. So there we go. Is that kind of what you're after? I don't think they're going away though.
No, I don't think they are.
Thanks very much.
It definitely makes the nurses happier as soon as the patient has a vac dressing on.
Yeah, I think we are pretty good at putting them on. I think there are parties, as with everything, there are parties who are more interested than others. I think also, actually you go for the other thing. It's very easy just to whack a vac dressing back on when you do a relook. But I think from our point of view, we do need to be thinking about actually, can we close this patient? And if we can't close it, is it worth whacking a mesh on and trying to ratchet it back together? Is there anything we can do to avoid a long-term vac? But I think that's an educational thing, because lots of these things are fairly new.
I think these are things obviously that we don't really have too much involvement with at the Glenfield at the minute, but that might well change with recon and different specialties coming across to us. It's really interesting to hear. Just have one question, because I know that you mentioned that one of the causes for fistulae is perforated diverticular. Yeah. But I might be wrong, but I do think aren't some perforated diverticular managed conservatively?
Yeah, I mean we quite frequently manage them. So it really comes down to what the patient's like and how sick they are. If you've got a kind of a tiny localized perforation, we'll just give them some antibiotics and it will go away. Although, to be honest, there's not much evidence for antibiotics. Clearly, they may get recurrent episodes, and that's kind of something to deal with. Someone with a kind of an abscess, the first route is again radiological drainage, if possible. If it's a kind of a localized collection, if they can drain it, that may turn into a fecal fistula. If there's a persistent collection with the diverticular, that you end up having a bit of poo coming out the drain. But again, over time, that usually spontaneously settles. And then the ones with kind of diffuse peritonitis, if it's a kind of a diffuse purulent peritonitis with no evidence of a kind of a ongoing big hole in the colon, if you like, laparoscoping them and washing them out and putting a drain next to it, again, is a very reasonable way of managing it. Way of managing it, particularly if they're fit enough for it to go wrong. I think if you've got someone who's elderly and they've got purulent peritonitis, and you go, they quite often get one shot at this, and I think in them maybe actually a smash and grab Hartmann's, accepting it will be a permanent stoma is actually beneficial. Obviously Hartmann's got the morbidity associated with it, and at least 50% of the stomas are permanent. But yeah, we do manage it conservatively quite frequently, actually.
It's interesting because it's the opposite way around to what you'd imagine. You'd think that the sicker ones you'd try and manage conservatively, but obviously they've probably got a better chance by just solving it in one go than leaving it.
Yeah, I mean, it's a differing mantra, depending on where you work. You could argue the simple purulent peritonitis, you resect and you can do a primary join on them. That's something that traditionally in Leicester's not been done. But again, they've got to be young and fit enough for that. I think it tends to be the older ones. If you think they're fit enough to go to the theatre, they've got one go at it, and that potentially that should be a Hartmann's.
Great stuff. Any other questions for Chris?
No.
Off the hook.
Have a good weekend, everybody.
Thanks, Chris. Thank you for that.
Bye.
Cheers.
Thank you.
So looking at the INPRESS trial, which was an effect, so it was an anaesthetic trial, perioperative medicine trial. So it was the effect of individualised versus standard blood pressure management strategies. And they were looking at post-operative organ dysfunction amongst the high-risk patients. As you can probably tell by the names, it was carried out in France. The background to the study was before the pandemic. Obviously, there was more patients and a more old and comorbid patient population having surgery. There's evidence, and obviously rationale as well, is that in patients, especially patients who are frail with high blood pressure, intraoperative hypotension would be associated with organ dysfunction. There was no, I don't think there still is any consensus regarding optimal blood pressure targets. This study was printed in 2018, and at that stage, the American College of Cardiology and Heart Association were recommending individualised care for surgical patients, comorbidities, and so their question was, in high-risk patients, does a strategy of targeting individualised systolic blood pressure compare to standard practice? Does it reduce organ dysfunction? So, as you can probably tell by the authors, it was 9 university and non-university hospitals in France, and it was carried out between December 2012 and August 2016. It was a multi-centre randomised controlled trial, and it was with one-to-one recruitment. They randomised online. It had the sample size they were intending to get was 268 patients, and aiming for a 90% power to detect an absolute difference of 20% in the primary outcome. They did recruit. They aimed to recruit 300 to obviously account for people withdrawing or people not following the protocol. The analysis was the intention to treat. It was internet randomisation. Obviously, the anaesthetist knew what arm of the trial the patient was in, but they then attempted to blind the follow-up team on ITU and also the data collection team for follow-up. You can't see that, but 1,494 patients were screened and 298 patients were randomised. So 149 each. The population was age 50 and above. They had to have surgery under general anaesthesia with the duration of more than 2 hours. They had to have an ASA score of 2 or more. And in the supplement, they did a perioperative acute kidney injury risk index of class 3 or higher. The people who excluded, so uncontrolled hypertension, where we consider cancelling in this country, already established chronic kidney disease, that would be stage 4 or worse, acute or decompensated heart failure, ACS, if they had sepsis, or if they're already on NORAD, and if they're pregnant and breastfeeding. So the intervention, so the people who were in the intervention arm got a continuous infusion of norepinephrine and ephedrine, and they were targeting a systolic blood pressure within 10% of the reference value. The reference value was what their blood pressure was measured at the preoperative visit, so the preoperative assessment. If that wasn't available, then it was their blood pressure on the morning of surgery. They reduced the infusion rate if the heart rate went below 40. Their control arm was intravenous ephedrine, 6 mg boluses, up to 60 milligrams, and that was every time the blood pressure went below 80, or if 40% lower than the reference value. And then if the systolic blood pressure didn't respond to ephedrine, then they would go to norepinephrine as a rescue therapy. a common protocol to both. So as I said, they aim to use the preoperative assessment. If all the patients had an art line, they had Hartmann's at 4 mils an hour during surgery, 4 mils per kilogram per hour. So 60 kilogram man, 2 hours of abdominal surgery would have got 4.8 litres. So it's quite a lot of fluid. The additional fluid boluses were given as starch, and then the intervention period lasted from anaesthetic to 4 hours after the completion of surgery. All other decisions were left up to the attending physician. This is just a slide showing that actually they did manage to randomise pretty well, and that the confounders were generally comparable in both groups. Most of the surgeries were carried out on the abdomen. There was non-cardiac surgery, but most of them were on the abdomen. Two of the patients, they started off with 149. Two of the patients withdrew their consent in the intervention arm. In the standard therapy arm, one withdrew consent, 2 had their surgery cancelled, and 1 was randomised incorrectly. And then 1 in each group, they deviated from the protocol. So the primary outcome was actually a composite score of SIRS and at least 1 organ system dysfunction out of renal, respiratory, cardiovascular, neurological, and coagulation. For coagulation, they used the SOFA score. So respiratory was need for ventilation or non-invasive. Renal was according to the Rifle criteria. Neurological was either a cerebral vascular event or GCS less than 14, and cardiovascular, I think, was the need for inotropic or vasopressors. The secondary outcomes was the individual components of the primary composite measure, then changes in hemodynamic variables. They did SOFA scores on days 1, 2, and 7. They did SIRS scores, any other post-operative complications, so mainly looking at things like infection or things that would normally be included in the primary outcome. Duration of intensive care and hospital stay, and then all-cause mortality in 30 days. What they found is that the intervention arm had a statistically significant reduction in events in the primary outcome, with a number needed to treat of 8 and the fragility index of 3. The secondary outcomes in the intervention arm, the renal dysfunction was lower, statistically significant, and the altered consciousness was lower, altered consciousness level lower in the intervention group. Again, statistically significant. There was no significant difference in any of the other scores. So on this basis, the authors concluded that targeting individualized blood pressure reduced the risk of post-operative organ dysfunction. The increased use of NORAD and arterial cannulation didn't appear to cause any adverse events. And then, oddly, I don't quite understand why they were using SIRS scores, but the association between their pressure treatment and the sepsis needs to be explored further. But that wasn't, the SIRS score was actually statistically significant. It was more a hypothesis generating investigation. The strengths of this study are it's multi-centre, it's randomised. They did manage to blind as much as possible. It is a relevant and important question. They also targeted a higher risk population. They had clear separation of the systolic mean and diastolic blood pressure at the end of anaesthesia, although it's probably not surprising considering the protocol. And although they did use a composite score, all the outcomes are relevant. There's a few weaknesses. Anaesthetists are not blinded. I can't say that it's necessarily standard care to take a 70-year-old with hypertension and CKD1 and target blood pressure just above 80 and use ephedrine. I'm not quite sure about the starch. There was a lot of fluid given, clearly. This took place over 4 years in 11 centres, and they managed to get 298 patients. They didn't get too many patients. They excluded a lot of patients due to AKI, not having enough risk factors. And basically, I can't say, as I said before, the standard practice, the standard arm isn't really reflective of current practice. Will it change practice? My own conclusions are this is kind of what most of us do. Most of us don't just come in the morning, not see our patients and target blood pressure 80 with ephedrine. So the standard care isn't really standard. I think most of us would assess a patient and look at what their normal blood pressure is. Should elective patients with hypertension actually have home blood pressure management monitoring? Because actually, I think in primary care, they're moving towards the idea home blood pressure is the most accurate and reflective of what someone's normal blood pressure is, not someone who's panicking and had a COVID swab shoved up their nose in the morning. Does anyone got anything else to add about that?
I guess what immediately springs to mind, I think the take-home messages from it are probably pretty sound.
Yeah.
You're not really comparing like with like, are you? You're comparing titrated NORAD infusion versus intermittent boluses of ephedrine given too late.
Yeah.
So it's not surprising that you get slightly better outcomes.
Did the ephedrine groups have an outline?
Yeah, they both have an outline.
It's kind of not surprising you get slightly better outcomes. It's almost like, I think there's a study they did for OBS a while back in terms of phenylephrine infusion versus boluses. Turns out that infusions are better.
Yeah.
So it'd be nice to compare like with like in that context, really. And even just the act of, I know you said the anaesthetists weren't blinded, even just the act of being told, well, you're targeting this blood pressure, or you're targeting, or only give ephedrine if the blood pressure is less than 80.
Yeah.
I feel the design could have possibly been a bit more rigorous.
Yeah.
Isn't it?
Yeah.
I mean, you don't have to use a NORAD infusion. We should try and be targeting a reasonable blood pressure anyway, no matter how we do it, whether it's fluid boluses or NORAD.
I've got a question or a point to make. I think we get very worried about the hypertensive patient who has treated hypertension and ensuring that their blood pressure is well managed. But could you not argue that a non-hypertensive on treatment actually has probably more likely to have a normal blood pressure than someone who isn't known to be hypertensive, and are we actually looking at the wrong group?
Yes. I don't think these patients were necessarily picked on hypertension. I think it was a pre-op, so they're aged 50 and over, then screened. I think it was just their normal blood pressure, so it was within 10 percentage points of their normal blood pressure. I think the average blood pressure is the average systolic blood pressure is about 130. I've just closed my slide. I think the average systolic blood pressure is about 130 in both groups.
Can you, the other thing, Dan, can you explain the fragility index?
So my understanding is the fragility index is the number of patients that would need to cross over from one group to the other in order to reverse the results or make the results non-significant.
Yeah. So what do you think about a fragility index of 3?
Well, it's about 1% of the total population.
It's not very many.
It's not a massive number.
Yeah, it's not a lot. And you completely change the outcome. So it's just worth thinking about that in terms of the results that you get. The other thing was, I know I'm hogging the questions, but you mentioned that people could start on NORAD if they didn't meet, or if they weren't getting their blood pressure targets by having ephedrine boluses alone. Do you know what was the crossover into that?
I don't know. I can't remember.
I've always found that ephedrine is crap.
Yeah.
To be honest. It
Well,
really works.
there was a bit of crossover from memory, but I can't remember what the numbers were exactly. Of people having quite low heart rates as well.
Hmm.
So there was crossover for both.
Cool.
I can't remember.
Okay. So do you think this is going to change your practice?
Well, as I said, I kind of feel like we already do, and I think most people have a rough idea, even if they don't formalise it. Most people have an idea of what's a suitable blood pressure for the given patient. I don't think many of us would just stick a number and go, that's my number for the over 50s.
That's probably fair.
Yeah, no, probably not, because it's close to what most of us already do, but not so formalised.
Fine. Does anyone else have any points or questions they'd like to ask?
We can see what the 65 study results are.
Yeah, that's true.
As a local,
Same thing.
but if someone was a hypertensive anyway, and then they had a blood pressure of 80, isn't that quite bad? It's the change, isn't it? It's not just that what the actual numbers are.
Yeah, the idea is the shifts in the autoregulation curves, especially organs such as the kidneys, the heart, and brain. So yes, the idea is having a lower blood pressure for them is more deleterious.
Yeah.
For instance, if you were under anaesthesia and your blood pressure was 80, that won't really at all. But yeah, someone who's 70, we wouldn't let it go that low. Certainly wouldn't wait for it to go to 80 before I gave ephedrine.
Cool, that's great. Thank you for that. You should be able to see a QR code on the screen. If people want to take a photo of that, you'll be able to provide some feedback, and you get an automatically generated certificate for your portfolios. Can you all see it?
Yes,
Yeah.
thank you.
Great. So next week, the speaker is Simon Scott, who's going to do stats part 2, which sounds dull, but is actually really interesting. The first session was really good. It is Rob Watson. I can't remember what the study is, but he's presenting the Journal Club next week.
Cool.